We have just finished Contraception Part 1. We will now proceed with Contraception Part 2. The outline of today's presentation includes 1. Hormonal contraception, which consists of combined oral contraception, COC, progesterone-only pills, POP, injections, and implants. The second topic will be on missed pills. The third topic on emergency contraception. And our fourth topic is on our conclusion regarding contraception. These are the mechanism of action for hormonal contraception. For combined hormonal contraception, the primary mechanism of action is by preventing the ovulation. Combined hormonal contraception acts on the hypothalamic pituitary ovarian axis to suppress the luteinizing hormone LH and the follicle stimulating hormone FSH, and thus inhibiting ovulation. Changes to the cervical mucus that results from the progesterone exposure may also contribute as a barrier to sperm. There are two types of contraception pills, which are combined oral contraception, COC, and progesterone-only pill, POP. We'll now discuss further on combined oral contraception pills. COCs. COCs are a combination of two hormones, estrogen and progestin. The dose of estrogen in a COC is low, 30 to 35 micrograms. COCs are packaged with either a 21 or a 28 pill pack. The 21 pill pack contains only active pills and requires women to take a 7-day break between packs. The 28 pill pack contains 21 active pills and 7 inactive or hormone-free pills. These inactive pills are included to minimize the risk of women forgetting to start a new pack of pills on time after a 7-day break. The 7-day period during which no active pills are taken is called the hormone-free interval. Most women have their menstrual bleeding during this hormone-free interval. The characteristics of COCs include safe and effective. COCs can be stopped at any time. There is no delay in return to fertility. COCs do not interfere with sex. However, they do not provide protection from any sexually transmitted diseases. COCs are beneficial for the symptoms of premenstrual syndrome. It also reduces the risk of recurrence of endometriosis after surgery. It can be used for the management of acne, hirsutism, and menstrual irregularities associated with polycystic ovarian syndrome, PCOS. There is a reduction in risk of endometrial, ovarian, and colorectal cancer. It can be used for the management of menstrual-related issues. Women should be informed that the risk of breast cancer and cervical cancer is low among women who use COCs. The estrogen component of the combined pill may slightly increase the risk of blood clots in veins or arteries, including a stroke, myocardial infarction, deep vein thrombosis, DVT, and pulmonary embolism. The risk of blood clots is higher, especially in the reproductive age women who have risk factors such as hypertension, diabetes, or smoking. This is why it is important to screen for existing risk factors prior to starting COCs. COCs must be discontinued immediately if thrombosis develops. Concomitant use of other drugs with COCs. Hepatic enzyme-inducing drugs could reduce the contraceptive effectiveness of all COC methods. Contraceptive hormones can also affect the serum levels of other drugs. Women using enzyme-inducing drugs should be informed that the contraceptive effectiveness of combined hormonal contraception could be reduced during the use of enzyme-inducer drugs. For example, women taking lamotrigine should be advised that COCs may interact with lamotrigine. This could result in reduced seizure control or lamotrigine toxicity. The risk of using combined hormonal contraception could outweigh the benefit. Hence, an alternative contraception should be considered. We will now proceed to progesterone-only pills, POP. POP or progesterone-only pills. POP contain only one hormone, progestin. They do not contain estrogen. There are different types of POP, but there are no clinical significant difference in effectiveness and characteristics. POPs are packaged with 28 pills which contain the same amount of hormone. There are no hormone-free intervals or break between the packs. Characteristics of POP. When counseling clients, it is important to help them consider how these methods of characteristics fit their lifestyle and reproductive health goals and desires. POP has no break between packs. It is to be taken at the same time every day. It is safe for breastfeeding women and their babies. POP can be stopped at any time and there is no delay in return to fertility. However, POPs do not provide protection from sexually transmitted diseases or HIV. This slide shows us the advantages of POPs compared to COCs. POPs can be used in breastfeeding women. It can also be used for patients who are contraindicated for estrogen. The thrombosis risks in patients with POP are low, and the risk of cancer is also very low compared to COC. When can COCs or POP be started? COCs or POP can be started from day 1 to day 5 of a menstrual cycle without additional contraceptive precautions. After day 5, it can be started with additional contraceptive precautions such as condoms or abstinence for 7 days. Now, we will move on to the injection method of contraception. Types of progesterone-only injectables. The first type is depot-medroxyprogesterone acetate, DMPA. It is given intramuscular every 3 months. It can be given 2 weeks earlier or 4 weeks after the scheduled injection date. The second type of progesterone injectable is norhistrone enactate, NETEN. This injectable is given intramuscular every 2 months. It can be given 2 weeks earlier or 2 weeks after the scheduled injection date. We must remember return to fertility is often delayed, an average of 9 months. The health benefit of the contraception injections include protection against endometrial and ovarian cancer, and uterine fibroids. It also reduces the symptoms of endometriosis. It also reduces dysfunctional uterine bleeding and helps with dysmenorrhea. When can you give depot injection? You can give depot injection immediately if you are sure that the woman is not pregnant, or during the first 7 days when menses have started, assuming she's not pregnant. You can start depot injection after 6 weeks postpartum in breastfeeding mothers or anytime within 4 weeks after delivery for those who are not breastfeeding. But if it were to be given after 4 weeks, pregnancy needs to be ruled out. For miscarriages, you can start anytime within 7 days. After 7 days, you need to rule out pregnancy. If you are switching from another method, you can start immediately as well. Now move on to implants. What are contraceptive implants? Contraceptive implants are progestin-filled rods, the size of a matchstick, that are inserted under the skin. There are 3 types of implanon that are available. The one that we have in our clinic kesihatan is implanon NXT. It's a one-rod system which lasts for 3 years. The characteristics of contraceptive implants include safe and effective. Fertility returns without delay when the implant is removed. It can be used by breastfeeding women. It offers non-contraceptive health benefits too. However, it requires a minor procedure to insert and remove the implant. And it does not protect you from any sexually transmitted diseases or HIV. The non-contraceptive health benefits of implants include reduce the risk of symptomatic pelvic inflammatory disease, PID. It also protects against iron deficiency anemia, IDA, and it reduces the risk of ectopic pregnancies. Complications from implants are rare. Among that is infection at the insertion site, difficulty removing, and expulsion. Side effects of hormonal contraception and the management. The possible side effects of contraception include nausea, changes in bleeding pattern, mood changes or headache, tender breast, dizziness, and slight weight gain or weight loss. These side effects often go away after a few months and are not harmful. How can we manage the contraceptive-related side effects? If it is a menstrual-related problem, we can give reassurance first. If the problem is irregular or heavy bleeding, mefenamic acid can help. You can consider a trial of combined oral contraceptive pills for 21 days to regulate the bleeding. You must exclude any gynecological condition if the problem continues. If the bleeding becomes a health threat and if it is unacceptable to the client, we can offer another contraceptive method. How can we manage other contraceptive-related side effects? If the side effects is headache or dizziness, you can reassure the patient and suggest good pain relievers. If the patient has abdominal bloating or discomfort, we can offer symptomatic relief. If they have changes in mood or sex drive, we need to exclude other causes. Patient that has gained weight, we can review their diet and counsel as needed. We will now proceed with missed pills. What do you do when you miss a combined oral contraceptive pill? If you miss one or two pills, take the pill from yesterday as soon as you remember. Then continue with the rest at the usual time. No need for extra protection. What do you do when you miss 3 or more combined oral contraceptive pills? If you missed it in the first week, take the missed pill immediately. Then continue with the rest at the usual time. Practice abstinence or extra protection for the next 7 days. If you had prior intercourse while you're missing on pills, consider emergency contraception. If you miss the pills in the 3rd week, take the missed pills immediately. Then continue until you finish the current pack. Omit the pill-free interval and start a new pack immediately. Don't forget to practice abstinence or extra protection for the next 7 days. What do you do when you miss a progesterone-only pill? If it is less than 3 hours, take the missed pill immediately. Then continue with the rest at the usual time. No need for extra protection. What do you do when you miss a progesterone-only pill for more than 3 hours? If you're menstruating regularly, take the missed pill immediately, then continue with the rest at the usual time. Practice abstinence or extra protection for the next 2 days. Consider emergency contraception if you had intercourse in the last 5 days. If you are breastfeeding and menses has not returned, you can take the missed pill immediately, then continue with the rest at the usual time. No extra protection is needed. We will now move on to emergency contraception. What is emergency contraception? Emergency contraception is used after unprotected or inadequately protected act of sexual intercourse. It is recommended for use within 5 days, but it is more effective when it's used as early as possible after unprotected intercourse. Emergency contraceptions can be used in the following situations: unprotected intercourse, failure of contraception method, incorrect use of contraceptives, sexual assault if without contraception coverage. Mode of action of emergency contraception is by preventing pregnancy by delaying ovulation, hence preventing any sperm from fertilizing an egg. The copper-bearing intrauterine device prevents fertilization by causing a chemical change in sperm and egg before they meet. There are 4 types of emergency contraception. The first type, levonorgestrel, 1.5 milligram, taken once a day, also known as Escapel, or levonorgestrel, 0.75 milligram, taken twice a day, also known as Postinor 2. The second type of emergency contraception is ulipristal acetate, 30 milligrams, taken immediately after sexual intercourse. It is also known as ELA. The third type of emergency contraception is a combined oral contraceptive consisting of ethinyl estradiol plus levonorgestrel, the USP regime. Intrauterine copper device is the fourth type of emergency contraception. Emergency contraceptive pills are most effective if taken as soon as possible within 120 hours. Ulipristal emergency contraceptive pill and levonorgestrel emergency contraceptive pill preferred to combine oral contraceptive emergency pills because they cause less nausea and vomiting. Side effects of emergency contraceptive pills include headache and dizziness, nausea and vomiting, breast tenderness, lower abdominal pain, mood changes, and irregularity with the menstrual cycle. We will now move on to the case scenario. Case 1. Katrina, 38 years old, is known to have high blood pressure with last reading of 140 over 95 millimeter mercury. She has been trying to give up smoking unsuccessfully, and at the moment she smokes an average of half pack a day, 10 cigarettes. She has 3 children, and because of her age, she does not want to have any more. But her husband is against either him or her having sterilization. Therefore, she's considering using a combined pill. What would be the ideal contraception for her? From the case given, the risk that she has would be borderline high blood pressure and smoking. Her blood pressure is 140 over 95 millimeter mercury, and she smokes at least 10 cigarettes a day. According to the medical eligibility criteria, she is suitable for progesterone-only pill, implanon, copper IUCD, and Mirena. Case 2. Nina, 18 years old, delivered a healthy baby 2 months ago. But she is not breastfeeding him because she had to be treated with anticoagulants after her childbirth due to deep vein thrombophlebitis in her left leg. She has been sexually active again for the last 3 weeks and would like to use the monthly injection. What would the ideal contraception be for Nina? The ideal choice of contraception for Nina would be copper intrauterine device. Case 3. Aina, 34 years old, para 2, has been using condoms for about 1 year with her husband. She has not had any other partner during that period, and she believes her partner is faithful. She would like to have a copper intrauterine device inserted. However, although her cervix looks clean, she has severe vaginal discharge. What type of contraception would you choose for Aina? For Aina, all methods of contraception can be considered. However, caution is needed with intrauterine device. In conclusion, option of contraception is individualized. Hence, the importance of us giving the correct education and providing access to the contraception. This is the list of resources used in this presentation. Before ending, we would like to thank FMS of PKD Petaling for reviewing our presentation. A special thanks to Dr. Naima binti Sharifuddin, who vetted for the exam questions. With that, I bid farewell and all the best in your exams. Thank you.